In what ways have you seen low-dose naltrexone, LDN, outperform corticosteroids or biologics in immune regulation, particularly in psoriatic arthritis or other autoimmune cases?
I have actually learned in various situations to use low-dose naltrexone in emergent situations where, for example, and I actually did a pre-recorded presentation for one of the conferences a few years ago on this, where it was an I think she was 84-year-old female who actually has Alzheimer's, but she was developing temporal arteritis. We know that is an emergent situation, and it wasn't a quick onset. However, especially with patients who have impaired memories, you need to go back and start looking at patterns. Again, a lot of it is patterns. Every time she was coming in, I see a lot of my elderly on a regular basis for just basic therapies and support their body. And she started having increase of blood pressure, and then her care team, who were her daughters, started reporting. She would sit there. It was interesting as it was becoming more of a prominent type of issue. That's where I said, oh, this is now. I started seeing it. I'm like, okay, she's having pain, but this is a elderly woman who has Alzheimer's. So it was very difficult to pick these things up. This is why talking to family members is also important with these populations. So I literally said, okay, we're gonna prescribe 2 medications. We're gonna do prednisone, because we want to make sure we don't have that emergency on our hand. But then I immediately started her on low-dose naltrexone, 1.5 milligrams, and within 24 hours, she didn't report, because they would keep checking in. She's like, no, I'm good. And then, of course, I would have her come in on a regular basis. Blood pressure actually, was going down, because heightened blood pressure can be a sign of pain. And so it was interesting that, of course, with every follow-up, we did actually increase to get her to 4.5 and never, ever, ever needed the prednisone. So that was just one example on how that happened. Another one was a patient who had just came in, was getting ready to go on a trip. He was a pilot, and he was like, oh my gosh, head to toe covered in a rash. And I tell people I don't do derm. Like, this is the funny thing, because I see a lot of it, believe it or not. And I said, okay, this is what we're gonna do. We're gonna try you on low-dose naltrexone, see what happens, but here, and there was something, I can't remember the situation, but he needed to have like a quick, we need to get your immune system under control type of scenario. So again, the prednisone, I prescribed it as well. I said, it's one or the other, and gave the directions, and sure enough, within 24 hours, actually the rash completely, it was about 85% to 90% improved, and he was able to do what he needed to do for work, and it was not a problem. And I can't prescribe biologics, just FYI, so that's why I usually get majority of these patients come in and they're already on them, and then I'm able to work with their rheumatologist to get them off.
There are a couple of papers that actually discuss the use of LDN at the same time concomitantly with biologics, and they've seen no interaction, and they've seen it as safe. What we're also finding clinically is a number of rheumatologists as well as GI specialists. They start saying, well, what is the lowest effective dose, and can we stretch the frequency, and can we start reducing? Because that's generally patient mediated. They're like, well, why am I taking this if I don't have any symptoms? That's always usually the first, like, why am I on this? Nothing's there. Well, it's working. Can we lower the dose? And now we're getting rheumatologists and GI specialists saying, well, how about, we've seen this in other patients, let's find the lowest effective dose, and we can keep it as a rescue and return if you do need. But once they start getting onto that path and they've been to,
I can clinically at least vouch for that, I'm a pain provider. It's pretty much what I do. So I regularly use naltrexone with psoriatic arthritis or Crohn's or lots of things. Also the thymic peptides, anyways, it makes sense, right? If we follow the physiology and we follow, every lecture we just talked about, modulation is a very different thing than a targeted inhibition. And that's what we're getting with LDN, and that's why it comes across as such a miracle drug, because it is easy to stack and layer on top of it as a foundational therapy to modulate and address different things. It's not to say I don't send people for a biologic or something. Sometimes, just like the prednisone case, you need to dampen something down and buy yourself some time so that there's not an emergent problem. But long-term, I think clinically, I would completely support what you're saying.
And another thing too, that, I actually have two, same diagnosis, ulcerative colitis, two very, very different responses. And one is being very well managed and was able to eventually get off of any type of medication that was used to help with that. I don't remember which one, but the other one, every time we try to introduce low-dose naltrexone, he almost immediately goes into a case of in the ER with bleeding. So that's where now I'm starting to go into more of the microdosing type things. And the fact that he still comes back shows the trust level, because he and his wife want to get pregnant. And I think he's on IV, again, I don't know which drug, I'm not good with these things unless they're in front of me. But he's on an IV medication right now, and even his gastro is saying, you know something, it might not be the best time to try to conceive, but it's not necessarily contraindicated, and they're scared. You know, because they say we don't know what the drug's going to do to his, production and that type of thing.